And now I'm excited to introduce Dr. Klugman. Dr. Klugman is a professor in the Department of Health Sciences and co-directs the Bioethics and Society minor. He conducts research and advises on pandemic health policy, having served as the chair of the Ethics Subcommittee of the Illinois Crisis Standards of Care Task Force, served on the Texas Pandemic Planning Group, and as a member of the U.S. National Biosecurity Science Board. He's been interviewed about COVID-19 and vaccine passports for the CBS Evening News, WTTW Chicago Tonight, ABC Chicago, and the Chicago Tribune. So without further ado, I will turn it over.
Great, thank you, Emily. It is a pleasure to be here tonight and hopefully give you a lot of information, probably more than you ever wanted, about vaccines and herd immunity, which is the topic that brings us together tonight. So please put your questions in the Q&A and we'll get to those closer to the end of the hour. So let us begin. I've been asked to give a disclaimer. I do serve on the DePaul Response Task Force for COVID-19, and so they've asked me to let you know that what I'm going to present to you tonight are my own professional opinions and not reflecting of the views or policies of DePaul. So this is where we are at this moment as of today. There are about 156 million cases that we've had worldwide on COVID-19, with nearly 33 million here in the United States alone. To give you some perspective, we are 4% of the world's population and 24% of all cases worldwide. Here in Illinois, we've had almost 1.4 million cases with a current positivity rate of 3.8%. And in Chicago, 277,000 cases with positive rate of 4.5%. To give you some perspective, I was talking to a friend in Texas earlier today who was very excited that they were under 10%. And here in Chicago, we're sort of panicking that we're up at 4.5%, but it is lower than it was 2 weeks ago. As far as deaths go, worldwide, we are edging up on 3.3 million deaths. And in the United States, 580,000. In Illinois, about 22,000. And here in Chicago, a little over 5,300 deaths as a result of COVID-19. Now, because we're talking about viruses and vaccines, I'm going to give you a little primer in what they are. So please bear with me if this is familiar territory for you. But I just wanted to make sure we all sort of have the same working knowledge and language before we move on. So this is an image of a virus. And a virus is actually a really interesting organism. They aren't living and they aren't dead. They exist and they have functions, but they don't fulfill all of the requirements of what we think of as a living organism. They don't have interest, they don't have stimulus response, and they're very simple in their structure, right? They don't have a nervous system. What exists in a virus is this green part here. This is the lipid coat, and you can think about this as the skin of the virus. Inside of the virus is DNA. In the case of COVID-19, it's RNA, and this exists inside the virus. And then we have these sort of purple things here that are called spikes. Sorry, I'm getting a warning that my internet is not stable. So if there is an issue, we'll take care of that. So the spikes they look like landing gear in a spacecraft, but what the spikes really are is this is how the virus grabs onto the cell. And that's it. This is the entire structure of a virus. It's got its outer coat, it's got its spikes, and then it's got its passenger, which is the RNA DNA. And what it does is it grabs onto the cell, it injects its genetic material into the cell, where it hijacks the normal operation of a cell and has the cell actually produce copies of the virus. So instead of making the normal proteins that a cell would make, it starts making copies of the virus. When there's enough virus, the cell basically explodes and it disperses virus throughout the body. That's essentially what it does. Okay, so, great, glad you can hear me. All right. So you can think about, so I mentioned there are DNA viruses and there are RNA viruses. So what is the difference between the two? In terms of like getting sick, not much. In terms of how do you build a vaccine, there's some differences here. So DNA is a double-stranded helix. You can see this picture here, right? So it's the double helix. It's the famous term that Watson Crick and Rosalind Franklin figured out and won the Nobel Prize for. Actually, just the men won the Nobel Prize, not Rosalind. And it stays in the nucleus. It's a pretty substantial sized particle. So it just stays here in the nucleus of the cell. It doesn't go anywhere else. And this stores genetic information. In fact, it's so good at storing genetic information that we're actually trying to store computer programs and music and things on them to see if this would work better than a hard drive. So we're playing with it. And it's fairly stable and long-lived, right? It lasts for a long time. Now, RNA is single-stranded. You can see a picture of it here. So it's just a single strand. That means it is more reactive, attaches to things more easily. It is also shorter lived. It's not quite as stable. But because it's a smaller particle, it can move throughout the cell, right? So it can move into the nucleus. But in terms of a virus, it tends to stay outside the nucleus because what it needs to do to hijack the cell, none of that stuff is inside the nucleus. It's all outside. And really the function, we have RNA in our cells now, right? So you have a regular cell in any cell in your body, you've got DNA in the nucleus, you've got the cell wall, and then you've got pieces of RNA that basically read the blueprint and then bring it into the cell where we build the protein. And in the case of the virus, it's just hijacking that procedure. So you can think of it this way. The DNA are the blueprints. It's this what it looks like to build the house, what's been planned. The RNA are the tools that you use to actually make the blueprint come to life. And then the actual house that we would construct, those are the proteins that we're making. Cells make proteins. That's the end product, right? So DNA is the blueprints, RNA are the tools, and then the end product is the proteins. In the case of a virus like COVID-19, the end product are more copies of the virus. So when we're thinking about vaccines for COVID-19, we have created 4 different kinds of vaccines based on 4 different types of technologies, which is kind of neat. So the first one is called a wholly inactivated virus vaccine. So this is, notice I have a virus on its side, it's supposed to represent it's dead, and it's got none of its RNA in it. So we can take a virus and weaken it or kill it. And so now you just have this coat, essentially. You inject this into the body, and it causes an immune reaction. So you develop antibodies and T cells that are primed. If they do come in contact with the virus in the future, they already know how to respond. So this is very traditional, right? This is your polio vaccine. This is your smallpox vaccine. This is pretty much every vaccine we've ever created before the 21st century. In terms of COVID-19, there are 2 different vaccines that have used this very old technology. So Sinopharm and Sinovac. The Sino tells us these are actually the Chinese ones. So these are both the Chinese vaccines. They have been distributed all over the world. And it turns out they're not actually that effective in terms of this virus. So it is a virus. We know that COVID-19 mutates a lot. It changes its RNA around. And the result of this is that in Chile, we don't really have the data out of China, but the data that's come out of Chile is that it's about 30% effective. Now, if this was a flu vaccine, 30% would not be considered a bad vaccine. A great flu vaccine is 50%. Flu vaccines are very highly mutable. They change every single year. But for COVID-19, this isn't the best. So this is very traditional technology. The second technology we've used is probably what you've all heard of, and many of you might have, which are the RNA vaccines, right? This is Pfizer and Moderna. Now, what these do, and this is new technology. It's been around for about 30 years. So what this does is it takes, now when you see under an electron microscope, this is what COVID-19 looks like. The colors have been added. There aren't really colors on the microscopic level, but it's to help us differentiate different parts of the cell. So the cell wall is this gray, and then the defining feature of a coronavirus, corona meaning crown, are these spikes, right? It's supposed to be like the spikes in a crown. So these spikes are what we have been targeting in most of our vaccines. And the spike is fairly stable. It doesn't seem to mutate very much. So what Pfizer and Moderna does is they took the RNA for the virus and they pulled out just the segment of the RNA that codes for the spike. That little segment of the RNA is what is the vaccine. So it's put into a suspension. The suspension, the fluid, is injected into your arm. Your cells of your body are exposed to it, and you have an immune response. So that's pretty simple. It took about 2 months for us to create these vaccines last year. Turns out it's a pretty simple technology once you have the capacity to do it. And so again, we are just this little tiny protein here for the spike. That's all that we're putting in. All right. Third is called a modified virus or a viral vector. Now, in the viral vector format, this is the Johnson & Johnson vaccine, the Janssen, the one shot that we've been hearing about. It's also the AstraZeneca vaccine that's been in the news because it hasn't yet been approved by the United States, but we're to other countries. Because it turns out we don't actually need the doses. We have enough of the other three. So what this has done is something fairly similar. So it's taking the RNA for the spike protein, but instead of just injecting the RNA into the body, we're trying to get it more directly into the cells. And so instead of putting it into a needle, put it inside of another virus, which sounds kind of weird. Well, one of the things that viruses are great at doing is infecting cells of the body. So we can have it do that, but this time we are controlling. So this is actually adenovirus or a cold virus, and the usual RNA or DNA has been removed, and instead it's the RNA for this spike protein that we're putting inside a cold virus. When you get your injection, they're actually injecting cold virus coats, the lipid coat, into you. That's carrying the RNA, and then it acts like a virus. It goes to the different cells and injects the RNA for the spike in there, and you get an immune response, right? So it has a very similar process to the Pfizer and the Moderna, the exception being one is putting it inside of this viral vector, the other is not. The last one is what's known as a protein subunit. So instead of like on the Chinese vaccines, we are giving you a deadened version of the full virus. Well, here, you're just giving somebody a little piece of the virus. Instead of the whole thing, we're just giving you the spike. And again, the body creates an immune reaction to the spike protein. And then if exposed to the virus, COVID-19, it already is primed. You've primed the system. There are T cells, there are antibodies that are ready to attack that virus to make sure you don't get sick and pass it on. So Novavax is the company that has gone with this technology. It again is a 2-dose regime, but it is using this method of just giving you that little tiny piece of the actual virus particle. Okay, so those are the 4 technologies that we're looking at as far as our vaccines. Now, there are different levels of effectiveness and different levels of dosing and how they're stored. So they have different advantages and disadvantages with all of these. If we look at this third column here, what they all have in common is they are 100% effective at preventing death and hospitalization. So people who have been fully vaccinated or immunized, which is 2 weeks after you've received your second shot or your last shot, then 100% of those people will not die or have not died and have not been hospitalized, which is great. Like this is the best thing. So it means the death rate should go way, 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 way down to 0 from COVID-19. Now, as far as protecting us from having a mild or moderate case, they vary in effectiveness there. So we see Moderna and Pfizer in the mid-90s. This is probably makes these the most effective vaccines that exist in the world. These are incredible numbers, and we never dreamed of it when these were created a year ago, when testing began a year ago, that they would be this effective. And these numbers are actually bearing out not just in the clinical trials, but in the real world. Johnson & Johnson in the real world is coming out at about 66%. So 2/3 of people on Johnson & Johnson will find that they don't get mild and moderate, but there's a third of a chance. Mild and moderate, we're not worried about that so much. It's not going to overwhelm hospitals. It probably won't cause the lifelong issues that we're seeing in some people. Novavax is around 90%. Sputnik, which is the Russian version, we've been told it's 92%, but nobody in the West has seen the data. AstraZeneca is coming out at 79%. The only one, they're all 2 doses except for Johnson & Johnson, which is 1. Now, here's where a lot of the advantages and disadvantages come in. It's a lot easier to get people to come into a clinic 1 time than it is to get them to come to 2. And this is becoming an issue now as we are vaccinating more people. Storage is also an issue. So Moderna and Pfizer have to be kept in incredibly cold temperatures, right? So this minus 20 Celsius, your freezer at home is capable of doing that. The minus 70, it is not. This is a specialized freezer. These others, 40 degrees, this is your refrigerator that we can keep these in. So Moderna and Pfizer, incredibly effective, but they require some specialized equipment. Now, we have had the FDA approve Moderna, Pfizer, Johnson & Johnson. Novavax is planning to file. Sputnik hasn't done anything, and AstraZeneca is under review in the United States. Moderna and Johnson & Johnson have been approved for people over 18. Pfizer's approved for people over 16. It is expected by Tuesday that the FDA will give approval for Pfizer for people over 12. Okay, that's very exciting. Pfizer also expects to be putting in for people 2 years and older by the fall. Moderna had just reported, in fact, this morning, its results for teenagers, and they said it is just as effective, so they're probably going to be putting in to allow over 12 in the next month or 2. And these are shifting. You might have heard about some issues with blood clotting in some people taking in Johnson & Johnson. There were 15 cases in the United States. 14 of those were women. So there is a recommendation that women under the age of 50 may want to consider not taking Johnson & Johnson if an option, but really we're talking about 1.5 million chance. And now that we know to look for it, we know to look for it so we can help treat it if it happens. As you can see, this next chart is how much of each one we've given out. So Pfizer is like the winner. And if we're trying to see which vaccine is most popular, being taken up the most, Pfizer is way ahead of everybody else with about 54 million doses given out. Moderna, we've given out almost 44 million doses, and Johnson & Johnson, which is the most recent of the ones to be approved, is at 8.4 million doses. But the difference is this is a single dose, these are double doses. So 54 million doses, you could figure about 25 million people. Moderna, about 20 million people have gone. Okay, so this talk is about herd immunity. And all of this were primers to sort of understand where we're sitting in herd immunity and what this concept is. So herd immunity, bizarrely enough, it sounds like we're talking about cattle, and in fact, we are talking about cattle. So the definition of herd immunity, as a bioethicist, I always start with definitions, is indirect protection from an infectious disease that happens when a population is immune either through vaccination or immunity developed through previous infection. So theoretically, there's 2 ways to reach herd immunity: that you have vaccinated your entire population or a good chunk of your population, or they have had the disease and they have maintained immunity. There was very early on, there was a program through the United States government, a policy under the Trump administration that we would go for natural herd immunity. What was not recognized is that because of the death rate of around 2% of COVID-19, that would mean about 20 million people in the United States would die if we went for a natural perspective. And that's sort of unacceptable in a civilized society. And so natural herd immunity has never been an approach that we could reasonably take. It would also mean a huge number of deaths worldwide. So that's not something that we've actually scientists have ever, or public health policy experts have ever backed up. So it's vaccination that's really our way to get to herd immunity. Historically, the term actually comes about in 1910. There is a viral infection in cattle. Of course, we didn't really know much in 1910. The germ theory of disease was fairly new, but a lot of cattle were spontaneously losing their pregnancies. And so out in the fields, the recommendation to deal with the cattle was to cull the herd, to basically kill all the cattle who were spontaneously losing their children. Until somebody came up with the idea that said, no, that's not what we should do, because those who have had this infection, lost their progeny, they are immune. And so they're the ones you want because they can't get the virus again. Whereas your naive cattle, the ones who haven't had it, can get it. And so you try and separate those. So we should not be culling the herd this way. And so the idea of herd immunity was that enough cattle were infected that they would protect those that were not yet infected or were separated. So literally this comes out of agriculture. Now in 1923, this concept was applied to human beings. A bacteriologist named W.W.C. Topley wrote in the Journal of Hygiene that if you had an epidemic in human beings, it could only end once the number of unimmunized people, what we call naive hosts, people that the virus could infect, was so low that the virus would have nowhere to go. Right? It would have nobody else to infect. And so he adopted this term from the cattle industry of herd immunity. And this is where it comes from. And it was tested later this same year when there was an outbreak among children in an orphanage. And the theory played out to be true, that if you got enough people that had immunity in the population, then it didn't spread any further. Now, there are lots of different diseases that we have vaccines for, and we know what the herd immunity rate is. So for measles, 95% of people have to have been vaccinated in order for it not to spread. Now, there are always going to be, with any vaccine, there's going to be a percent of the population who, for medical reasons, cannot get vaccinated. They may have a disease, they may have an allergy to an element in the vaccine. So flu vaccines are incubated in eggs. So if you have an egg allergy, you actually can't get your flu vaccine. And so by this is the herd immunity idea, that if the vast majority of the population is immune and the virus can't get a foothold, and viruses survive by jumping from host to host to host, if there aren't enough hosts, the virus can't jump around, so you won't get an epidemic. And so we protect those of us who get immunized, protect the people who can't get it for medical purposes. So in measles, 95% of people need to be immunized for us to protect those who can't get it. You might have heard a couple of years ago about a huge measles outbreak at Disneyland. And that was because the rate of immunity actually dropped below, I think it was like 84% at the time. And so all the children who got it were pretty much naive. They were not immunized. But because there was enough hosts for the virus to get a hold of, to jump into the host, that this happened. Polio is at 80%, so it's a lower number. Mumps is 86% herd immunity. COVID-19, we don't have the exact number yet, but we can do calculations. There's mathematical formulas for figuring this out. And so as Dr. Fauci has said, that it's somewhere between 70 and 85%. But we can't know yet until we've actually reached that point and it sort of fizzles out. The pandemic fizzles out once we get to that point. So his goal is, let's not worry about the number. Let's just get as many people vaccinated as we can. In the United States, as of today, we have about 148 million people, or 45% of our adult population over 16, has been immunized, which is amazing. This is huge. A year ago, if you had told anybody that we would have nearly half the people in the United States immunized, like nobody would have believed you. And then about a third of us are fully vaccinated Fully vaccinated means we've had 2 shots and it's 2 weeks past the last shot, or 1 shot of Johnson & Johnson. And then you can see here breakdown by age. If you go to people over 65%, over 65 years of age, 83% have had 1 dose. And if you look at over 18, it's 56%. So these are great numbers, but this is not 85%. So we still have a ways to go. You can see on a national map here, the darker blue are the states that have had more saturation. So it's the percent of the population that has had more vaccines. So we can see places like Wisconsin, South Dakota, New Mexico, the entire Northeast, they're vaccinating at very high rates. Where you are seeing low rates of uptake of vaccine are the Deep South, Idaho, and Wyoming, Indiana. So you're seeing conservative states, very conservative states are having low uptake. These are also places, probably not surprisingly, where we have seen the most cases. Here in Chicago, it's been an interesting experiment to see how the distribution has happened. So this is January 2021. This was a month into, was 6 weeks into us having the vaccine. We started distributing December 15th, so we're 6 weeks into this. And what's fascinating is this is replicated in cities all over the country. And what you see is where the deaths have happened from the COVID vaccine, you're not seeing it on the north side, you're not seeing it in the downtown or the west areas, you're seeing it in the poor neighborhoods and the neighborhoods of color. And then where were we vaccinating initially? The exact opposite, right? So this darker, again, the darker colors, higher vaccination, darker colors here, higher death rate. So we were vaccinating exactly the places where we were not being as impacted with deaths and cases in the city. The reason is pretty simple, that in January, we were vaccinating 2 groups of people, healthcare workers and first responders. And actually 3, and people over age 65. So it turns out most physicians work in these areas and they don't live in these outlying areas. And most nursing homes are also in these areas. And so that's why the initial rollout was this way. You might see these couple of outlier neighborhoods here. And these are actually the neighborhoods where most of our first responders live. And so that's why they had high uptake of vaccine and low cases and deaths. Now, fast forward 4 months later, and the city has made efforts. So there are the sites at the United Center and at Chicago State University are taking people by zip code with the attempt of trying to get these neighborhoods that didn't have high vaccination availability in the beginning, but have really been impacted by the epidemic. And so what you see now are a lot of those neighborhoods where we had high rates but low vaccination. It is now evened out more. So we're also running more mobile clinics. We're taking buses into these neighborhoods. So we are bringing the vaccine to where the people live. So there's been much more evening out of that. This part of it has not necessarily happened nationally because it takes a concerted effort to happen. That's in the United States. If we want to look worldwide, this gap is far worse. So this is a map of where vaccine doses have gone worldwide. Again, the darker the color, the more doses. As you'll see, the United States and the UK are being vaccinated at higher rates than anywhere else in the world. And it turns out that this has to do with who bought vaccine doses. Last year, the Trump administration gave billions of dollars to private companies to create vaccines. And we had no idea who would be successful and who would not. So we gave lots of money out. So Merck was one of the companies that got money. Their vaccine did not do terribly well. They're actually now producing Moderna vaccine, but that's money we won't get back. But we paid a lot of money for this. So it turns out that high income countries, HICs, represent 16% of the world's population and have received 87% of the doses. So when we're worried about who gets the vaccine in the United States, are we going to give it to our seniors? Are we going to give it to our healthcare workers? Do we give it to teachers? Do we give it to students? Worldwide, it's who can pay the most money. And so, yes, 5 months ago, the United States had the most cases and the most deaths. And so we have the most of it. There was a piece on NPR about 3 weeks ago about Canada, who also has money and ordered a lot of vaccines, are not getting a lot of their deliveries because they didn't pay quite as much as the United States. The US paid more money, so we're getting doses first. Now, if you look at middle income countries, this is 75% of the world population. They've gotten about 13% of all doses created. And low income countries, which are 9% of the world population, has gotten 0.2% of all doses. 0.2. So when we think about India, which is having a humanitarian disaster right now, people literally dying in the street of COVID, they're middle income. And they're not getting everything they need. So it just gives a broader perspective about how well the US is doing. We have further to go, but compared to the rest of the world, there's some imbalances and injustices here. And in fact, these low-income countries are likely not to get their COVID vaccine until 2023 or 2024. Right? So we're still 3 years away from being able to have enough vaccine for the entire world, 8 billion people to get vaccinated. Okay, that's a little sobering. What we're finding here in the United States is a slowdown in the number of people who want to take the vaccine. And this is a problem. So vaccine hesitancy is the term we apply to this, right? And it is defined as acceptance or refusal of a vaccine despite it being available. Like right now, there is vaccine availability. In fact, most states are not using their full supply. If you go to downstate Illinois, it's really easy to find because people just aren't taking it. They don't want it. And we'll talk about that division in a moment. Whereas here in Chicago, you can get it everywhere. You don't necessarily need reservations anymore, but there's such a demand for it that it's not like there's extra doses laying around. But are we at a point, there's been such a slowdown, like we were 2 weeks ago, 3.3 million doses per day, and that's amazing. Now we're at a 2.75. And it's not that there's less, there's more available, there's less people coming out for it. We're not at herd immunity yet. So what are the factors that are involved with people choosing not to get the vaccine? Well, it turns out to be a somewhat complicated picture. So part of it is political. So as you can see here, the orange line is I'm vaccinated or I plan to get vaccinated. The sort of light green is I'm going to wait and see what happens. I'm not ready to go there yet. Green, definitely not. And the blue, only if it's required. As you can see, Democrats, almost 80% of Democrats are going to get it. They're out there to get it. Republicans, only 45% say they're going to get it. More Republicans say they are not going to get the vaccine than say they are going to get the vaccine, and independents are in the middle. Again, we're not quite hitting herd immunity levels if we look at this 62, 63%. Now, it's better if it's mandated, and so for the fall, DePaul has mandated that all students will have to be vaccinated. It also turns out, beyond whether you're Republican or Democrat, if you support Trump, you are less likely to get vaccinated. If you support Biden, you are more likely to get vaccinated. So people are thinking politically about this, which is really unfortunate. Also turns out your religion may be a predictor of whether you are likely to get this. So as you can see, 85% of people who are Jewish are planning on getting the vaccine. And the religion that is least likely to are, well, it turns out, so you can't quite tell here, but it's people who identify as evangelical Christian. So this group, these are the evangelical Christians, and white evangelical Christian, more than anything else, is more likely to be hesitant to take the vaccine. We can see Catholic and other Christian are again very high in uptake. Race is also a predictive factor, and so is education, and they're really hard to separate those out. So people with 4-year college degrees or more are much more likely to take the vaccine, these blue lines, to accept the vaccine than people without a four-year college degree, right? And it's dramatic differences. Ironically, whites are both more and less likely to get the vaccine. So if you are an evangelical Christian white Republican, you're like 80% chance that you are not going to take the vaccine. But you break any part of that up and it changes. So education level is associated with hesitancy as well as race. Now, what this sets up is what we call the freeloader problem, right? And you can think about this as the coffee in your office, right? So if you had an office and there was a coffee and everybody chips in once a month or once a year to help pay for the coffee. The freeloader is the person who drinks the coffee but doesn't contribute to paying for the coffee, right? They think they can get a free ride here. And this is what happens sometimes in herd immunity is people who say they want the benefits of the vaccine. They want to be able to eat inside of a restaurant, to go to a concert, to go to an art fair again, but they don't want to be the one that gets the vaccine. So they want the benefits, but they don't want to do any of the work required to get there, right? Now, there are people who have legitimate medical or religious reasons for refusing the vaccines. And it's for them that we pursue herd immunity. So we want to get to the 85%. So for the 15% who can't, they're still protected. But there are these people who don't have a religious reason, don't have a medical reason, but are just saying, I don't want to do it. And they think they will get the benefit, but we won't get the benefit if there are that many freeloaders. So this is a known problem in public health. And the question is, how do we convince enough people to get it that we can get to herd immunity? So I want to go through some questions, some things you may have heard about reasons that people are choosing not to get the vaccine, that they are hesitant. These come from studies that have been done across the whole country. They also come from some of the studies we've done here at DePaul about our own population. So first, it's only approved for emergency use. I don't want to take an experimental vaccine. I actually got this one yesterday. So when you think about emergency, don't think about experimental. When something is brought to the FDA, a company is applying to the FDA to get their drug approved, the normal process takes a couple of years. But there is this emergency process where if the company can show that this is safe and effective, that there's a faster way for them to get there. So it's not that it's emergency because it's experimental, it's just that's the name of the bureaucratic pathway that these have been sent through because it's faster. Okay, so now Pfizer has begun the process of applying for the regular approval, but that's going to take a minimum of 6 months. So the fastest way we could get these vaccines out to the public were this particular paperwork pathway. That's all emergency use means. It's the paperwork pathway. And to give you some perspective about how we didn't cut corners. So phase 3 clinical trial, that's where we really find out if it's effective. We've looked at the safety profile, but now we're looking at a large number of people to see how this works in the real world. In a normal phase 3 trial, we would recruit 1,000 or 10 to 10,000 people. Right? 10,000 would be a huge, enormous, most are around 1,000. And we use these numbers because we are trying to prevent harm from subjects. It's research ethics. We want to prevent as little harm as possible. And so we use smaller numbers over a longer period of time. In the case of COVID-19, the pandemic was seen as a public health emergency that is worth exposing more people to the vaccine. So the trials for each one of these drugs was 65,000 people. Normally 1 to 10,000, each one of these was 65,000. So if we think about it in terms of people years, if you have 10,000 people, an enormously large trial, and you watch them for 2 years, it's 20,000 people years. COVID-19 was 65,000 people over 9 months. Actually, we're continuing the trial. They're still all in the trial. But over 9 months before we got approval, that's 45,000 people years. So it's 2.5 times the statistical power of a normal trial. So we actually were more rigorous for our vaccines than we are for normal drugs and vaccines. So it's not experimental. It is safe. It is effective. The technology, the RNA vaccines are 30 years old. The first vaccine developed on this was actually the Ebola vaccine, used this RNA technology. It was just the paperwork pathway. All right, another reason. I've already had COVID, so I have natural immunity. I don't need it. The answer is you do need it. So we know that this natural immunity doesn't last a very long time. Estimates are that it's probably about 90 days or 3 months that you maintain the antibodies once you've had the infection. And if you've had a mild case of the infection, it's even less. Okay. Now we know that from our trials, we've been having clinical trials of our vaccines for a year now. May represents a year. And those people, everybody in the trial still has immunity. Okay, we'll probably need boosters at some point, but right now it's still looking good. So the CDC, the Centers for Disease Control and Prevention, recommendation is that even people who have had COVID get the vaccine, especially if you only had a mild or moderate version. You definitely need the vaccine. They say, and you can get it 2 weeks after your last symptom of having had a COVID infection. All right, so you still need to get the vaccine even if you've had COVID. The vaccine's against my religion. So this is one of the ones that I've heard about. It turns out all major religions have encouraged people to take the vaccine. All of them. Not a single one has said, nope, don't do this. Pope Francis actually came out several months ago who said, I believe that morally everyone must take the vaccine. It is the moral choice because it's about your life, but also the lives of others. So religion says take the vaccine. I don't want to become infertile. So this is a rumor that's been going on, and it is complete misinformation. There is no reported problems with fertility. In fact, we're recommending that pregnant women get vaccinated because it turns out they pass the antibodies on to their infants, their fetuses and their babies. And so it's good to get vaccinated if you are pregnant. In fact, the CDC, I was looking this up this morning because a family member asked me about this. The CDC has found there is not a single vaccine that has ever affected fertility. So it's not been an issue. There is, however, that I think this is where some of the confusion is coming. There are some reports of changes to menstruation after the vaccine. UIC is doing a study looking at this. So they're looking, if this has been you are welcome to do that. But that's not necessarily affecting fertility. It's just affecting menstruation. A lot of people faint after they're getting the vaccine. So this was something that was happening. And a study was done to examine this phenomena. And it turned out that people weren't fainting from the vaccine. They were fainting because they had anxiety about getting an injection. It was actually needle anxiety that was causing the fainting, not the vaccine itself, which is understandable. Needles can be scary. I'm around people who are not getting vaccinated, and I don't want to give COVID to them, so I shouldn't get vaccinated, right? So there is this misinformation going around the internet that if you have the vaccine, that you could spread COVID to other people. Well, here now you know why I sort of did all of this, sort of here's the science of vaccines in the start of this talk. It is not possible for you to be spreading that virus because none of these vaccines contain live virus, not a one. So the idea, if you get a natural COVID infection, you shed virus, right? You have virus particles that other people can catch. But in the vaccine, you are getting tiny little pieces of RNA or tiny little pieces of protein. There is no way, it doesn't convert. The spike protein doesn't suddenly spontaneously become a full-on virus. It's just not possible. The laws of physics prevent it. And so this cannot happen. I don't want to get the side effects. I will say this, 70% of people do experience side effects to the vaccine, to any of the vaccines. The side effects, however, are mild. The only one we've seen that is not mild is Johnson & Johnson, where there have been blood clots. Again, it is 1 in 500,000 people, mostly women, who have had this. And that's why there's sort of, if you're female and under 50, you are informed about this. However, the risks of getting the vaccine are still considered by the CDC and the FDA to outweigh the benefits of the vaccine, are still outweigh the risk. The side effects for everything else are temporary, they're short-lived. And if you want to think about the risk-benefit ratio, your risk of dying from COVID is 1 to 2%. In some of these variants, it's actually 3 or 4%. And the risk of death from the vaccine is 0.0017. So it is exponentially riskier to get COVID than it is to get the vaccine. And those are the statistics and the data. You don't need an opinion there. That is the real world. The vaccine costs too much. Well, the vaccine costs you nothing. The United States federal government purchased 600 million doses of these vaccines, of the 3 leading ones. And that is enough for every person in the United States. You do not ever pay for the cost of the vaccine. If somebody says we're charging you for the vaccine, it's probably a hoax. They can charge a fee for administering the vaccine. Your insurance covers this. A lot of hospitals and clinics and public health services, if you don't have insurance, they don't charge you the administration fee. We did that in our DePaul clinic. So if you didn't have insurance, DePaul just covered the cost for our students if they couldn't pay for it. But there is no cost for the actual vaccine itself. So how do we get these people who are hesitant, who don't want to get the vaccine? We can educate them, right? I went through all those sort of myths and the misinformation because I wanted you to have the real information, the scientific information. So please go out and share that. When people say to you, yeah, I don't want infertility, like it doesn't happen. That does not exist. The CDC has examined those claims. It's not true. So we can educate people. But there seem to be some incentives, we call carrots, in terms of carrots and sticks and a horse. And the carrots are better than sticks, right? So we know that there are some of those people who said, I'm only going to get it if it's mandated. So we could have mandates. So DePaul's requiring all students to have it in the fall. Other experiments that have tried and seem to work in terms of getting people to want to be vaccinated is we give them paid time off. So a lot of companies are giving you a day off to go get your vaccine or a few hours. Some more recent programs are giving you free haircuts or free concerts or free baseball games. So the Seattle Mariners, the New York Yankees, and the New York Mets, if you get a vaccine, you can actually go to the stadium, get your vaccine there, and go to the game for free. And that's working. It's drawing people. You can pay people. So it turns out giving people $50 or $100, they'll get the vaccine. Like if they're on the fence, that's enough money to make them go over. We can also make it more convenient, right? So numbers started to rise in neighborhoods that hadn't taken vaccine in Chicago when we started bringing it into those neighborhoods. We started visiting people who were homebound and we brought it to them. We started bringing it on buses. We're bringing it to offices and places of worship. And so making it easier to get. And then vaccine passports. So the state of New York has what they call the Excelsior passport. Chicago is going to come in a couple of weeks with what they're calling Vax Pass. And this is going to be an app on your phone. It will be verified with the city and the state list of who's gotten vaccinated. And it'll just be, like clear to come, clear not to come. So your private health information won't be there. But if you want to go to, say, Taste of Chicago in June, you'll have to show your Vax Pass. And that means you can go in and you can be confident that everybody else is in there has also been vaccinated. So it's how we can safely get together. So this is the carrot. You get to do things. You get to go back to the before time, the regular life. So these are all incentives we can use. So where do we go from here? President Biden just yesterday announced that he thinks we can vaccinate 70% of all American adults by July 4th. This would be amazing. It requires overcoming a lot of hesitancy, and it is the lower end of the potential for herd immunity, right? 70 to 85, it's the low end. There are other people, as you can see here, who believe we're never going to reach herd immunity. It's not going to happen. Just forget about going back to regular life for a while. Also yesterday, the United States came out and said they're going to support waiving the patents on these. So Moderna and J&J and Novavax, the patent should be waived so that other countries can actually create these. Right? We're never going to, the manufacturing, the 2024 date, the only way to get that lower, to reduce the amount of time it's going to take to get everybody an injection, is to manufacture more. And so we have to allow more people to manufacture. which means not only waiving the patents, but also making sure that the raw materials to make the vaccines get out there. There are strange shortages that are also limiting the rollout. So the little glass vials that you've been seeing pictures of, that's in a shortage worldwide, those glass vials. These vaccines are actually brewed in large metal vats, and they're lined with plastic bags. There's a worldwide shortage of those plastic bags. Strange things that we have to kind of work on. So we're going to keep encouraging people to vaccinate. We're going to keep our eye on the variants. This has been something that's affected the UK and India, Brazil. And so keep an eye on those variants. And we're in a race now to immunize as many people as possible before a variant develops that can get around the protections the vaccines give us. We can waive the intellectual property, and what we can do individually, get your vaccination, continue wearing your masks, continue distancing. Right. So thank you. That's my presentation.
Great. Well, thank you so much. I know you answered a number of questions throughout your presentation, and we have a couple questions here from our audience that have been submitted in Q&A. So so we'll go ahead and start going through those. The first question says, speaking to vaccine passports, this person said, are there plans for a physical or printed vaccination pass for people who don't have smartphones? And maybe on that note, can you also speak to any concerns about inequalities or how the Vax Pass can help further fight the spread of COVID?
Sure. So the Vax Pass essentially would make sure that only people who have been vaccinated get into certain venues. It would probably be publicly run venues, but businesses could adopt it as well. Now, if you don't have a smartphone, then at least in the New York model and Israel, which is the other place that has been using a vaccine passport, you can also print it out. So it's available on paper. And that means that if you don't have access to technology, you can have it. But the inequality here still exists, right? If everybody doesn't have access to the vaccine, then people who have the passport are going to be people of means and who have had access to the vaccine. So it's really important that we keep up our efforts, which have been really good here in the city, but need to continue to make sure that we make the vaccine available to everyone. So that's that. But yes, in both the New York case and in Israel case, you've been able to get a physical printed passport. There's actually somebody who was just arrested because we get these, when you get your vaccine, I'm gonna dig mine out, you get this card from the CDC, and I'm going to show it here so you can't actually get my details. But so it's shining off of it. And the card, this person was basically making fake ones, and so they were prosecuted and have been sent to jail for this. Mine is actually laminated, so that it is pretty permanent. But some places are giving out little stickers. Mine is all handwritten, and apparently the little stickers react to the heat of the lamination. So if you have a sticker on your card, don't get it laminated. Otherwise, Staples and Office Max and Depot are laminating for free. So I didn't pay for this lamination. So you can just bring them in and they'll do it. The vaccine passport in New York was used for basketball games, one at Madison Square Garden, one at the Barclays Center, and they're hoping to roll it out further. The one in Chicago is still theoretical. There was a letter to the editor in Tuesday's Chicago Tribune saying, please don't do this. But it's probably going to happen, and we'll be announcing it in the next couple of weeks.
Great, thank you. For our next question, you mentioned earlier that some of these vaccines will now be given to younger kids, or I think 12 for Pfizer is what you said. This person asks, will the vaccine dosage be different for adults versus children?
No, in the clinical trials, the doses were the same. And your first dose is exactly the same as your second dose. There is no difference.
Okay, that was another question I've heard people ask recently. This next person, circling back to sort of more of the spread of COVID, can you speak to what we know now about the spread? Is it airborne? Should we all still be wiping down our groceries? And is it spread through surfaces, or just kind of sum up an answer on that?
Sure. So surfaces are not something to worry about, right? It's the CDC's come out and said there's a 1 in 10,000 chance of getting infected off of a surface. Now that's not if you handle 10,000 things, you'll get it. It's every single time you pick something up, it's a 1 in 10,000 chance. There is not a single case in the 33 million cases. There's not a single one that has been found to be caused by touching surfaces. You don't need to wipe down your groceries anymore. You do need to continue washing your hands though, because we touch our faces. It is droplets and it is airborne. And it's not, so yes, it's both those ways, which is why if you're not vaccinated, you have to wear your mask everywhere you go. And even if you are vaccinated, you need to wear your mask when you're in crowds. And crowd is defined as more than one other additional household.
Great, thank you. For some of our other questions here, you mentioned at the end of your presentation that the US is now supporting sharing the vaccine patents. Can you maybe just shed light on sort of both sides of that argument? It seems like it's become sort of a contentious topic, and just speaking to what people are for it and people that are against it, for those of us who are less familiar.
So it's really an argument of the role of capitalism and how much the government should control the marketplace, right? So patents have existed since before we had a constitution in the United States, right? It was the first law that the Continental Congress passed was patents, and this was to protect innovation, and it's something that we've felt very strongly about. So the idea of waiving a patent is not something that the government would take lightly, and it is the extraordinary circumstances here that really leads us there. There's only one other time in US history that the government considered waiving a patent, and it was in 2001, in the days after 9/11, when we were having an outbreak of anthrax. And it wasn't natural anthrax, it was actually bioterrorism that people were planning in anthrax. And so the government wanted 12 million doses of Cipro, which is what you use to treat anthrax, to have on hand. The company that made Cipro, Bayer, said it'll take us 2 years to get there, to make that much. And so there were other generic manufacturers that said, we can get there in 12 weeks. So the United States considered waiving it, but Bayer said, we'll figure it out. And so we didn't have to. But it's really, how much should the government be interfering with the market and with the capacity for these companies to make a profit? So that's one side of it. The other side is we're in this worldwide emergency that's we've never been in this situation before. We've had this necessary preventative vaccine that could save so many lives. And so that's the sort of other side, is to waive it. The US has recommended to the World Trade Organization, who would ultimately make the recommendation to waive the patents. So I'm seeing in chat, do people have had COVID count towards herd immunity? The answer is no, because as I talked about, that immunity is very short-lived, 3 months or less. So we are only counting people that are vaccinated. I will say, for the passport purposes in Israel, that if you have had a negative test, you also can have a passport for like 2 weeks after that negative test. So that's something that they count. And again, we don't know what Chicago's going to be doing.
Awesome. Well, we are almost out of time. Maybe just one quick last question. I know you spoke, obviously, extensively about herd immunity. When we're talking about reaching that herd immunity, what role does starting to vaccinate younger adults and children play? Will that impact us reaching herd immunity and faster, or is it really more so just starting to address some of the vaccine hesitancy in the scale that you showed of planning to do so, haven't done it yet, hesitant, won't do it when I'm mandated?
We need to be doing both, right? So in terms of viruses, they see children the same way they see adults. Like, they don't care, they'll infect both. So we need, like, being able to vaccinate people who are 12 and over. That's very exciting. We definitely need to do that. We also need to be getting people who are hesitant to being vaccinated. That's really important.
Awesome. I think most of the questions we've included in the chat we've kind of covered.
There's one here. Why do you feel sick after the vaccine? And that's really simple. So sickness is not getting invaded by a virus or a bacteria. Sickness is the body's response to the invasion. And in a vaccine, we're tricking the body into mounting that same immune response. And the body's only got so many tricks to dealing with invader. It can create a fever because the higher temperatures tend to, like these microorganisms invading us, they don't do well in higher temperatures. So the body raises the temperature and the body. So all these different things, like there's only a small handful of tricks a body has. The vaccine is tricking the body into thinking it's being invaded, so it mounts an immune response, because the immune response means you get antibodies and you get T cells and B cells. And that is priming the immune system for if it does get invaded, you won't get sick the next time. And so you are not getting sick, you are mounting an immune response, but it feels and looks like getting sick. The difference is it's also way shorter, because the other piece to know about the RNA virus is the RNA doesn't last very long. It's short lasting. So it goes into your body, you mount an immune response, and then it's gone. Your body absorbs it and you no longer. So it doesn't stick around, those RNA particles. But the immune response, the ability to counteract if you do get invaded, that's what stays.
Definitely very interesting. I think maybe one of the last questions that we have in here that we haven't covered also is just if you could expand maybe upon what concerns we have about variants generally and some of the variants of concern that were identified earlier this year. And maybe on that note too, do you think we'll be expecting booster shots down the road, or is that sort of, unknown territory as to what things will look like in the future, or whatever thoughts you have on that?
Absolutely. So, all right, variants are basically mutations, right? So a variant means it's the virus, but the RNA has changed a little bit. And what we've seen in the variants around, and there's close to 100 different variants going throughout the world right now. Most of them are very minor, small terms. Some of the variants are less effective, and so they don't spread. There's a handful of variants that we really are concerned about. The Brazilian one is very concerning. The one from India is very concerning. There's one in California that we're keeping an eye on that really seems concerning. UK variant, that is the one that we are actually mostly seeing now in the United States. And why these variants are concerning is they're spreading. Why are they spreading? Because they are more effective at spreading. They are more virulent, virus virulent, so they spread more easily. The UK one is 60% more infectious. Right, so you need to, when you get infected by the virus, like one virus particle is not going to make you sick. You have to be exposed to an amount of the virus. We don't really know what that amount is right now. We just know it requires an exposure to a certain level of the virus. In these variants, you need to be exposed to less of the virus in order for it to make you sick. So that's one thing. The other thing is these variants are more deadly. So when they get into your body, they do more damage. That's why they are concerning. So you have more sick people, you have more people dying, and the potential for overwhelming the hospitals, as we're seeing in India, is much, much greater. So that's why we're watching these and are concerned. The big concern, what keeps everybody in public health up at night, is a variant that changes that spike protein. Because all of our vaccines are about making sure our bodies identify and respond to the spike protein. So if you have a mutation that changes that spike, the vaccine, our bodies will no longer recognize it. And so it could make the vaccines not work. So that's the nightmare scenario. The good thing is, just yesterday, Moderna came out and said that they have a booster shot, and their booster shot includes all the existing variants. So it turns out these RNA vaccines are pretty easy and quick to change up to deal with the variants. And so their boosters, including it right now. They're not distributing the booster because we don't know if we need it yet. The thought is, so to answer the other part of your question, we believe that this is kind of going to become like the flu. So we're going to be living with COVID-19 for a very, very long time. And in order to do that, vaccines are going to have to become a regular thing. So I think that it will be part of our childhood vaccines, is that, you've got measles, you've got mumps, rubella, diphtheria, typhoid, and you'll get COVID vaccine. And you will probably get, for at least a while as adults, we are going to be getting, like you get a flu vaccine every year to deal with the variant. You will also get probably an annual COVID vaccine to deal with the variants for a few years until and eventually it will become a childhood disease. Once it's run through once we have that sort of herd immunity, children then become the naive hosts, and then we'll be dealing with them. So that's my guess about what's going to happen. But for the next few years, yes, we will be taking some sort of booster, and eventually it'll become more like a childhood infection.
Great. Well, thank you for clarifying that. Thank you again. Oh, we have one more question that popped up from the Q&A.
Okay.
And then we will let everyone go. I know we're a few minutes over here. This person asked, mask wearing in Asia has long been a practice. Do you think that's something that we'll see here?
It's funny. I talk to a lot of people on Zoom, not in the real world. But, this is a conversation I've been having with a lot of people. Even though the CDC says when you're out walking around, if you're by yourself, you don't need the mask, I'm still wearing my mask. A year ago, I started wearing my mask because it was about protecting other people that I could transmit to them. And now, like when I see somebody walking down the street, I don't know if they're not wearing a mask. Is it because they're vaccinated, or is it because they just don't care? And so now I wear a mask to protect me. And that's my feeling. Yes, there's a long tradition of wearing masks in Asian cultures because they're communal societies. And people wore them when they had a cold so they wouldn't spread it to somebody else. In many cases, they also wore it because pollution can be really bad in some, especially the Chinese cities that don't have pollution controls and regulations like we do. So there's very practical reasons for wearing it. So I'm kind of thinking that, yeah, there will be more mask wearing, thinking about going into an L train. And there's a lot of people there you don't know. I really appreciated that. I didn't get a winter cold this year. We didn't have a flu season this year. Like, there's advantages to this that go well beyond COVID-19. And the reason that I'm going to keep, one of the main reasons I'm going to keep wearing it, especially in the winter, because there's more transmission of viruses in the winter than there is in the summer, because there's less sunlight and we're inside more. They're warm. They're really warm on your face. And they're less intrusive than a baklava. So yeah, I'm going to wear it because it's warm in the winter. That's a big part of it as well.
That is so true, and a perfect note to end on from someone also living through Chicago winters. I know we have people from all across the country on this webinar, but as someone living through a Chicago winter, mask wearing this winter was really a perk. It kept it a little bit warmer. It was a little bit easier to run outside when you were covered up. But yes, thank you again so much for pulling this presentation together, for taking time out of what I know is a very busy schedule to lead this webinar for our alumni. Thank you all who joined us this evening. Thanks so much for coming and learning a little bit more about what we can expect. We are doing a sort of similar webinar next week that will be on the post-pandemic economy and what one of our faculty experts, Dr. Michael Miller, is seeing and reading about what we can expect moving forward from that standpoint. So I hope we'll see some of you there. But of course, again, Dr. Klugman, we really appreciate you joining us, and have a great night, everyone. We'll see you all soon.